Today I will be speaking about non-psychotherapeutic approaches for the treatment of genitopelvic pain and penetration disorder. Psychotherapy, of course, is being performed as a hidden message on my title.
Tamam, sağ ol. Şu oka basıyorum değil mi? Tamam. Sunum akışımı şöyle planladım.
Painful sex puzzle. I will be speaking about it as there are different terms in the literature. And I will be speaking about hysterical development, when the first time it was, the treatment was started, what kind of contribution there has been in the diagnosis, current treatment, non-therapeutic approaches, and then I will finish off as such. Painful sex puzzle, I say, because these are the definitions that are being used in the literature. Genitopelvic pain and penetration disorder is relatively new as a concept. Vaginismus, dyspareunia used to be the terms used. The rest, actually, we are not very familiar in psychiatry. Vulvar vestibulitis syndrome, provoked vestibulodynia are the other terms, but the only thing is it's a disorder that is being managed in a multi-disciplinary way. Gynecologists and sex therapists are also dealing with it. Most of the time, these patients are being referred to the psychiatrists, the gynecologists.
Uygulanıyor ve
Medical therapy is also applied, and we'll take a look at the history. As a matter of fact, the oldest evidence goes back to 18th century BC. From the antique Egypt evidences, we understand that the first diseases were seen in these times and was for the first time defined by James Marion Sims in 1861. On vaginismus is the title of the article. Sims is a gynecologist, is considered as the father of gynecology. Not only vaginismus, but other discomfort and disorders were studied in this way and defined as a contraction of the vaginal muscles that would not allow for penetration. In treatment, when there is a contraction, he said, let's make a cutting of the muscles, and then we shall make a vaginal dilatation through glass dilatators after the operation. How about referrals to psychiatry? Dyspareunia is actually the first term being used in referral. Psychophysiological genitourinary disturbances actually is the definition given in DSM-2. Dyspareunia is considered as painful intercourse. Many studies followed later on, and you should know Master and Jensen. Virginia Johnson, a nurse, William Hasters, a gynecologist. Different interpretations were there about this disturbance, but there was not a lot about evidence-based medicine. Therefore, these names are quite relevant. For 20 years, they looked into male and female sexual behavior in scientific laboratory conditions. They recorded the values under lab conditions. Therefore, they have had a thorough investigation of pathophysiology of reproductive function. Biphasic theory is accepted, such as the stimulation and orgasm, and then these are defined as the two phases, as defined in the process. Later on, Helen Singer Kaplan has a big contribution in this, American psychologist, and then comes a psychologist for the first time on stage. Beyond organic situation, she had many investigations from in terms of the mental health. Still current knowledge actually forms the basis for the methodology we are using today. For vaginismus therapy, couple therapy, she recommended. In the past, it was accepted as a problem of female, but later on, couple therapy, thanks to her contribution, was introduced as a rescue. Um, Relationship therapy and behavioral exercises containing sexual treatment principles were applied. Actually, for dilatation, catheter or other tools were used, but Kaplan showed a big contribution of the spouse's finger for digital stimulation, and we're still using this technique. Back then, Kaplan defined the mechanism of this disturbance as conditioning. Conditioning generally leads to pain and fear, emerging with an attempt of vaginal penetration. These are the women who develop a phobic reaction to vaginal penetration. As a result of this phobic avoidance, the attempt of intercourse will become painful. Thanks to these, of course, studies, DSM was open to the sexual dysfunction under psychosexual dysfunction heading. Also in DSM 3R, sexual pain disorder was the name attributed to vaginismus and dyspareunia. After Kaplan, Rosemary Basson came to be the person who provided significant knowledge and experience to the last 3 decades, a psychiatrist this time from UK, working on sexual medicine, and she's been a director of the sexual medicine program for quite a long time in the UK. There is a circle she's speaking about. Pain is there in a way, but what is important is catastrophizing the pain. There may be the influence of the partner as well. Later on, there is somatic hypervigilance, um, negative emotions, and fear and anxiety can be highlighted, avoiding penetration. Therefore, there is an increase in pelvic floor hypertonicity. And quite naturally, there is decline in lubrication. When this is the case, pain will emerge. As the pain emerges, the vicious circle will restart. What is important there is contraction and pain would be the focus point of the psychologists in the past, but this is not the result, they say. The result is that these individuals are catastrophizing this pain. Therefore, DSM-5 had to change the diagnostic criteria. As for DSM-4, as in DSM-3, vaginismus was considered as a repetitive, involuntary spasm in the outer one-third muscles of the vagina to prevent coitus. In definition, I can say it's quite difficult for us. I mean, one-third of the external muscles of the vagina, because we used to say the person allows for penetration, but also coitus is avoided. But if the person allows for intercourse, dyspareunia, organic or not, I mean, there is this definition that was not clear. As a result, the DSM-5 was changed to combine the two diagnoses, not to combine the two diagnoses, but at the same time to bring a different perspective to diagnosis. Speaking of criteria A, when there is any one of these diagnoses, this penetration disorder may be during vaginal penetration, or pelvis may be suffering from a significant pain during the attempt of penetration. Or the third one is when expecting a vaginal penetration because of the penetration itself or the expectation of penetration, the fear or anxiety. It's not a condition that the pain is there, it's just expectation anxiety that would make us diagnose this case. The other one is extreme contraction of the pelvic floor muscles during vaginal penetration. When this is the case, we can have a more integrated approach in our perspective. What is the approach of current psychotherapy then? What is the recommended treatment for psychiatrists? Um, Combined with systematic insensitization, gradual dilatation techniques, relaxation exercises, um, to treat the phobic element, because this is something catastrophized that becomes phobia. It's important to consider this way. Another one is to alleviate the conditioned vaginal reaction, because as a result there can be pain or burning sensation or contraction in vagina. The other diagnoses, these are not actually the diagnoses we were quite familiar with, but it's being used quite commonly by gynecologists. Why to know?
Bununla aramamız gerekiyor. Çoğun
Because if we want to have access to more number of cases, we should also have an idea about the literature. It's not always about vaginismus or dyspareunia. We may not have access to sufficient data. Therefore, we should know the difference. Briefly, vulvodynia actually is defined as a hypersensitivity of vulva without any pathological finding whatsoever. Through a sexual or non-sexual mechanical stimulation, permanent vulvar pain is characterizing vulvodynia. Vulvar vestibulitis syndrome is more like a penetration pain. So this would resemble something like a psychological background in vulvar vestibulitis syndrome. Provoked vestibulodynia is another syndrome. Actually, there is no pain there, but if, I mean, for pelvic examination or penile penetration or tampon usage, there will be some pain, as the studies indicate. But pain centered. It's a cause, there's pain, and we are going to treat this pain. Let's speak about treatment. Pelvic floor, physical therapy, electrical stimulation, or biofeedback, where the vagina is placed a device to trace the contractions on the monitor. So the contraction and relaxation is also followed by the person herself. This is involuntary contraction, but of course it's important to make it more voluntary, controllable. Now you see it's contracted now, it's relaxed now, it's something visible, so you should be more mindful of that. This is a combined therapy. Pelvic floor physiotherapists apply a strengthening exercise for pelvic floor, which also the individuals continue at home. Another part is vaginal penetration. The catheters or these kind of tips can be used by the physiotherapist, and depending on the condition, the patient herself may progress these catheters into the vaginal entrance. I mean, there are cases who say, I've treated vaginismus in a day. It really helps, but what is important is how your perspective is for the vaginismus treatment. If the perspective is only for penetration, there is a chance to resolve in a day. What do the studies say? Systematic review I've looked into, and that one involves 43 studies in provoked vestibulinia patients. Physical therapy also applied to the subjects. Um, 70 to 80% of the patients report improvement in pain, but most of the studies do not have a comparative group, and the efficacy is quite high. This is a compared study, a comparative one. Also in PVD patients, 21 patients randomly were uh, put into sexual therapy, CBT, and psychosexual outcomes were followed. In 6 months, scales were used to assess the sexual functions. In both groups, there is a significant decline in sexual pain. I mean, so both of the methods are comparable to each other to alleviate pain. But in the group that completed CBT, sexual functions improved significantly as well. What are the other methods? Topical steroids are also being used, lidocaine, for instance. Once there's pain in a given area, creams also may help. After that, the penetration will be allowed. And sometimes unexplained pain in the vulva can mimic other chronic pain as well. Therefore, antidepressants that are known to affect on chronic pain are also recommended. I'm not going to get into the details because this chapter, I mean, this part of the session rather discusses the organic aspect of the matter. This study is also another randomized and comparative study. Also, in this study by CBT, they compare topical steroids. 97 PVD patients included, randomized into CBT and topical steroid group. Both groups had a significant reduction in the level of pain. So the topical steroids were found to be sufficiently effective in reducing pain. But in catastrophication of pain and improvement of sexual function, CBT is superior. So the authors, especially on most of the cases, would recommend CBT. Hormonal therapies. Dyspareunia due to menopause also is another entity. Actually, since approved by the FDA, ospemifene should be emphasized as estrogen receptor modulator. In the presence of vulvovaginal atrophy, improvement and treatment of dyspareunia can be also achieved by this agent. Vestibulectomy, as used a century ago, is the surgical method being used today as well. This is the excision of the vestibular mucosa, where there is an intense pathological fiber accumulation of nerves. Here, why here? Because this is really very intense in terms of the nerve fibers, and there is a pathological intensity. Therefore, this portion is excised, as you can see on the slide. How about efficacy? This is a study that was conducted back in 2020 between 1991 and 2003. Vestibulectomy patients were examined. About 20 years passed, and the pain scores were rechecked after 2 decades. In average, in about 4 months, the pain alleviates significantly, allowing for sexual intercourse. The scores are 97% better when compared to past, and the authors indicate that it's really an effective therapy, but these are gynecologists. How about comparative studies for vestibulectomy? Actually, this is quite an old study. I think it was in 2000 that it was published. A triple comparison performed this time. Um, New York, Canada um, run study. Um, the today's authors that are quite famous are all involved. Three gynecologists, physiotherapists also involved. In this respect, we can say that the study provides um, group cognitive behavioral therapy, surface electromyographic biofeedback, and vestibulectomy in the treatment of dyspareunia. Patients were randomized. Biofeedback lasted for 12 weeks. CBT lasted for 12 weeks. So all the three groups had a significant improvement, but vestibulectomy group was superior to the other two in terms of pain scores. But the authors were suspicious. They say these findings should be supported by other studies. For instance, 7 of the patients in this group quit the study. They withdrew from the study. So they emphasize that the results should be repeated. Another study, the more recent one, 2019, a comparison this time, surgery and conservative therapy. 16 patients in vestibulectomy group, and conservative group is 50 patients undergoing physiotherapy, topical creams, TCA. It's a retrospective cohort study. The patients who received surgical treatment were assessed in 2 months. Pain scores were lower in the surgical group. So vestibulectomy seems to be superior as a treatment, but in 36 months they reassessed, and when they reassessed, they couldn't find any significant difference in between the groups. Yes, vestibulectomy may have a contribution, but in the long run, the results could be comparable. So should we go for vestibulectomy because complication rates is 18%? As for the final words, I will conclude by saying that genitopelvic pain and penetration disorder may lead to pain that has a multidisciplinary approach requirement for treatment. In terms of the clinical treatment, the pain should be handled in a multidisciplinary way. And yet, sexual therapists do have a central role. Therefore, CBT or relationship interventions may lay the grounds for treatment, together with physical exercises for couple therapy. I think this way because medical treatments may contribute to pain and contraction therapy, but in the long run, especially to improve the sexual life and want to do something in the long run, uh, want to have a minimal intervention to the patient. This way, therapies should also be considered effective. Okay, thank you.